So this, originally I was going to do like a how to read an EKG lecture, but that's like really incredibly boring. So I did a whole 180 and just picked out really difficult EKGs. So we're gonna start with that. See. All right, so this is gonna be very interactive. So just shout answers. I know Esteban's gonna shout out a bunch of stuff, but I want everyone to participate. So this is a 43-year-old male with chest pain. What's going on here? Sinus rhythm. What makes you say sinus rhythm?
There's a P QRS.
P before every QRS. What else?
Regular.
It's regular. The rhythm's regular. Okay. What's the rate? Less than 100, greater than 60? Okay. Are the P waves like are they like the correct axis? Someone says yes. Why are they the correct axis? I hear some mumbling, but in normal sinus, you're typically up in 2-3 in AVF and down in AVR. Also, the PR interval they look pretty consistent. All the P waves look the same. Right? Is there anything else, any abnormality in this EKG? T wave flattening in 3. This is a code heart. No. Yeah, this is a normal EKG. Sinus rhythm, also no, you don't see any really significant ST elevation or depressions. Lead 3, you can be a little low voltage. That's kind of normal. And then, look at the R wave progression here. It's typically S wave in these leads. I actually can't see my mouse, huh? And V1 through V3, and then like R wave dominant V4 through V6. All right. So this is kind of like a baseline. All right, next EKG. All right. How do I get? Oh, here we go. So this is the 88-year-old. So this is a patient I had, 88-year-old female with hypertension, presents with burning chest pain for 3 days. What's going on here? Send the patient out to the waiting room. See. What's the most obvious stuff? What's the eye popping here? ST elevations, which leads? Yeah, V2, V3, V4, V5. You guys see any Q waves? Pathological Q waves? V3. Kind of where all the ST elevations are. Yeah, this patient had pain for 3 days. You see any reciprocal like depressions? Maybe an AVL. You don't really see anything obvious. What would you guys do with this patient if you got this EKG? Yeah, so this patient actually, I was about to sign out and I was waiting for the next attending, and I actually didn't get this EKG. I'm like doing some notes, and all of a sudden I hear a code heart, and it's Dr. Glazer from his office. And I was like, who's this patient? He's not even here. And there's like orders for aspirin, Plavix to call the transfer center is calling the phone. But yeah, she actually went to MIMO and got 100% mid-LED occlusion. So we talked about TPA too, but did not get TPA. See. All right, this is just the kind of the ECG criteria for a STEMI. These are just, these are suggestive, so these are not end all be all. So basically, you have new ST elevations in V2, V3 that are kind of it's based on your age and based on your sex. So greater than 2 millimeters, equal to greater or equal to 2 millimeters in men greater over 40, and then 2.5 in men under 40, and then 1.5 for women. And then any other lead, you need 1 millimeter in contiguous leads. See. All right. So this is a 29-year-old male presents with syncope. So sinus rhythm, great. Okay. Someone says LVH. What makes you say LVH? Someone says QRS in the lateral leads. What's abnormal? Yeah, so the QRS complexes in the precordial leads are very tall. What else? Someone asked if this patient has hokum. What makes you think this is hokum besides anything else? Felipe says dagger Q waves. Where do you see dagger Q waves? So 2-3 AVF, so very narrow Q waves that are fairly large. Yeah, and V4, V through V6, yeah. Big amplitude in septal leads. All right. Patient is young, and the presenting clinical presentation, right? So yeah, there's pathological Q waves here, and typically in V1 through V3 you don't have tall R waves. Usually you're S wave dominant. So this patient had a hypertrophic cardiomyopathy. So this is just kind of just comparing to a normal EKG. You guys, what else can give you tall R waves in the septal leads?
RBA, DOPD, WPW.
So Esteban says RVH, WPW. What else? What's if the QRS complex is wide? Right bundle. What about any ischemia can present with tall R waves in the septal leads? Posterior MI. All right. And also it could be a normal variant, so that's not very helpful. But this is a list of kind of something to think about when you get these EKGs. It's a little bit abnormal, or you can see it in like young patients. And maybe you'll diagnose Duchenne's. See. All right.
Also whenever you go through an EKG and all the steps we've been talking about, and then you see a kind of a pattern, though, you always have to correlate it clinically. So here you have a 28-year-old who syncopized, probably on, let's say, on exertion especially. So right away, what you're going to push up is, what is an 28-year-old on exertion syncopized that's consistent with this, right? And you're going to come up with hokum, most likely. So you always want to correlate things clinically. It's not just having a pattern, because there's many things that can fit a pattern.
All right, next EKG, 76-year-old presents with med refill for their BP meds. Their BP is high, so they got an EKG. So what do you guys think? What's the rate here?
50.
Yeah, it's somewhere between 40 and 50. Someone says second degree block. What makes them think that?
I think that right after the T, the wave that's right after the T looks very similar to the P wave.
Where's our mouse? Yeah, so I think what Max is pointing out, so there's the P wave here, and then there's another upward deflection at the T wave that looks almost identical to the P wave. So what's happening here? drop beat. So this is 2-to-1 second degree AV block. All right.
So that person saying they might be weight.
So you can take the.
So you can,
Measure the PR and the one that's there. If it's the same every time, then you know it's linked. If it's random, then it's gonna be different.
you can use your calipers too. You should all have, good. But actually in Muse, you can actually, there's calipers built into the Muse. And you can actually march out your P waves.
Yeah, just need a piece of paper.
Okay.
That's about the old too. When you do have the R wave, you're always gonna have the PR, as Silverberg pointed out, that's gonna help you. Right, you'll see P's without QRSs, but you'll never see a QRS without a fixed P in front of it.
Exactly.
Always type two.
All right, 67-year-old with history of CKD presents with just full body dolor. Let's see. What's going on here? Is this sinus rhythm? Someone says sinus tech. Yeah. So you can see actually see P waves in V1. What else is going on? This is right axis. Okay. So kind of down in one and up in AVF. What about the morphology of some of the waves, T waves? Someone says peaked, but they don't look that tall, right? Not really. Maybe it doesn't look quite like. Are you talking about like Brugada? Maybe, but I don't. It's only in one lead. See. So this patient's potassium was 7. So these, you don't always have to have tall T waves to be hyperacute. I mean, to be peaked. In these T waves, they look abnormal, and that T wave should be asymmetric, right? They look pretty isosceles looking T waves, if you remember geometry. Typically T wave, you have a slow uptick, going up slow, and then you drop off real quick. See. All right. 80-year-old with hypertension, diabetes presents with palpitations. Is it sinus rhythm? Someone says no. Someone says AFib. What makes you think it's AFib? Irregular. You guys see any P waves or flutter waves? Maybe, but they're not all identical, these little deflections. What's the rate here? Yeah, so pretty fast, somewhere between like 120 and 150. So this is AFib RVR. What else can give you kind of, irregular narrow complex tachycardia besides AFib? SVT is very regular. What about irregular? Yeah, so you can have a flutter with varial conduction, and an MAT. Those are kind of the 3 big ones. Multifocal atrial tachycardia. Yeah.
And there you're gonna see usually more than 3 different kinds of P waves in that same lead, in that rhythm strip when you have MAT, right? That's going to give you the clue. And again, always correlate things clinically. Usually MAT, you're going to see in patients with bad COPD, right? And that's when you're going to suspect it and look for it.
And MAT, you'll see, yeah, you'll see P waves here. You don't see. All right, 60-year-old presents with epigastric pain after eating. Yeah. Resident wants to send the patient home, but you convinced them to get the EKG. See. So 2, 3 AVF elevations. Anything else? So AVL depression is probably reciprocal to these 2, 3 leads. What else? Yeah, what are anything abnormal about the T waves?
They're hyperacute.
They're hyperacute. They're really big compared to the QRS complex. Yeah, you could fit the QRS under them, inside of them. Any other depressions? And this is pretty subtle.
V2.
So V2, and there's actually pretty decent sized R wave here. So what else? What could that be indicative of? So pretty possible posterior involvement. There's also elevations here, V5, V6. What's the diagnosis here? Someone says STEMI. This is MI. What? Probably inferior, maybe some posterior and lateral involvement. Right. And this patient had an RCA occlusion.
Again, remember, anytime you have an inferior MI, you're going to hear you see the inferior lateral. We're still going to do right-sided leads and look for right ventricular as well.
And the other thing is, for specifically inferior, 3 and AVL are essentially mirror images of each other on the ECG. So if you look at 3 and you flip it upside down, it's exactly what AVL looks like. When you see hyperacute T waves in 3 and you see a T wave inversion in AVL, that doesn't necessarily meet STEMI criteria just yet. It's kind of more ammo to say, like, this is definitely, like, if I continue to get EKGs, they're going to become ST elevations later. So you can kind of act on it soon.
Yeah, whenever you see like an abnormality in AVL inversion, you should instinctively look at the inferior leads, I think, and vice versa. Right. All right, 65-year-old male presents with dyspnea, weakness, and dizziness. So widen QRS. What's the rate here? Slow, right? Yeah, it's probably less than 40. Is this sinus rhythm? So what do you guys think? Just look at this rhythm lead here, or even this here. Hear a lot of mumbling. Any? Someone says 1st degree heart block. Someone says 3rd degree. You guys see any? So what I think here is there's P wave here, and then there's another hidden P wave in the T wave. So probably can't be sinus. Also very slow. And then these P waves all are pretty march out. They march out. So it could either be 3rd degree or 2nd degree. I agree. It's probably 3rd degree. with you have a widened QRS2. The PR intervals do look like they're pretty consistent, but if you actually, get your calipers out, they're not consistent.
Last one, the PRS 2 boxes, and the first one, the PRS 3 boxes.
Yeah, good.
It was slowly getting shorter.
Yeah, and then the escape rhythm is wide, so it's probably coming from the ventricles, right? So it's unlikely, sinus. So this is, you have AV dissociation with a ventricular escape, and that's kind of right in the right, rate. You're
The third degree.
it's third degree. Yeah.
And look also at those T's and 2, 3 and a half, those big inverted T's, they also something laterally. So it's have to worry, maybe there's an underlying theory of mind there, which can lead to hot blocks and brain finding.
Yes. Yeah. What Dr. G said, consider ischemia, especially in inferior MIs. They can, third degree, it can present as third degree heart block. Oh, that's a good case. 55-year-old presents with palpitations. Stable blood pressure. You guys, what's the rhythm here? What's the rate? So 150, good. The sinus? Someone says yeah. Others say no. You guys see any P waves? What's your differential here? SVT, someone says sinus tach. What else? Flutter. I think that's pretty good differential. What do you guys want to do here?
Almost all those letters are SVPs.
You say SVP,
Yes. So you try vasovagal maneuvers, doesn't work. So give adenosine. What else could you give? Give fluids, you give a AV nodal blocker. This patient got adenosine, and then this happened. So what's going on here? So this is what type of rhythm is this?
Is it better or worse?
All depends on what.
So are there any P waves here? Are there any P waves here? Yeah, so this is sinus. All right, what's like the eye popping here? Someone says inversions, someone says depressions. Biphasic T waves. So you have tall R waves here in V2, V1 through V2, V3. So what's your differential? Someone says posterior MI. This patient presented as SVT. What could this be? Do the QRS complexes look kind of? So Esteban says WPW. What makes you think that? Because that's on the list differentials of tall R waves in V1 through V3. So yeah, delta wave. So you have a slow slurred upstroke of the QRS complex. You can also see it in these leads too. And lead 1, and AVL. And I think the PR is pretty short as well. If you look in this lead 3. So this patient was transferred to Bellevue concerning for an accessory pathway.
Is that a right side organ block? Yes. Is that a right button? Right, that's not a different.
Yeah, it could be. You also have another RSR prime. See, yeah,
Typically, right, your prime is bigger than the ROA, so the ball is reversed, and you don't expect, it doesn't look like a standard or something.
yeah. So what Dr. Haas is saying is that typically the rabbit ear on the left is smaller than the one on the right. Yeah, see, in the right bundle.
I mean, the comment on this is that, I mean, the treatment of adenosine wasn't necessarily the wrong thing. Because it was very irregular. It's not like
Yeah.
it was irregular, like can happen with this kind of antidromic thing. And they were orthodromic there. So adenosine is just like showing that they have the accessory pathway, but it doesn't necessarily say that you're gonna put them into like what we fear when we say don't give like the AV blocker to full Parkinson white.
Yes.
That's only for the anthem, so I think if
Yeah.
you say giving it to anybody with a regular rhythm,
Yeah.
you can pretty much, even if it's a wide complex, if you think, you're safe, you can benefit anybody regular.
Yeah, so like seeing this, like we found this afterwards, it's like, it's not like anyone did anything wrong. It's like, okay, cool, they have full Parkinson white.
You can give adenosine WW. It's usually only if they're not in WW with AFib, because that can become VFib. But you know, a lot of times you don't know, and it's safe to give it in regular, even if it's wide, regular tachyarrhythmias. All right.
What if they have a history of WW going straight for Panama, or just gonna use whatever you can, whatever's quick?
I'll use propanamide.
Again, remember the WPW has two ways of going, right? It can go the more dangerous way when it goes right down that bundle of Ken. And then it's gonna be wide, and it's gonna be, and if it's with pre-excitation AFib, it's going to be irregular. And that's the dangerous one, when it's wide and it's irregular. But the most common way it's going to go is to look just like any other PSVT, paroxysmal SVT. And as long as it's, especially if it's narrow and regular, you're not going to get into trouble with it. Just don't. And a lot of times this happens. You don't even know they have WPW. You break the PSVT, and you say, "Oh my God, it's now they have underlying WPW. Did I put them at risk?" No, you didn't, because you did the right thing. It was pointed out over there, right? You didn't do anything wrong. If you had given it when it was irregular, and especially when it was wide and irregular, yeah, then you did something wrong. You can kill them, right? Especially if you use the calcium channel blocker, but not here. So you just made your diagnosis.
We'll be going over wide complex tachyarrhythmias later this year. See. All right. What is this? So 6-year-old male with 6-year-old presents with amlodipine refill. This is their EKG. Sinus rhythm. We'll say, yeah, CP waves, pretty regular. What's the morphology? Anything abnormal? So Ryan says right bundle. I agree. So this is a typical right bundle, sinus rhythm right bundle. You have the rabbit ears in the anterior leads. You kind of also have these S waves that are kind of fat in one V5 and V6. But this is just a regular right bundle. Patient should go home after their med refill. Yeah, because their blood pressure is 180. So, right. All right. 80-year-old male initially presented as general weakness and altered mental status, now is in cardiac arrest. But this is their EKG right before cardiac arrest. See. Yeah. They also have a distended abdomen. Someone says junctional rhythm. Is the morphology of these T waves QRS complex, they look abnormal? Someone says peak T waves, wide QRS. So someone says give calcium for the treatment of hyper K. So you guys should, like, especially, you're a county in downstate, you should have this kind of this pattern memorized. You have kind of right axis, there's no P waves, there's wide QRS, the T waves are peaked. This patient actually arrested like 10 times, I remember. He got so much calcium, his calcium was like 14 or 15. And he actually did well. He got dialyzed, extubated with a mental status. So the K was, I think the K was like 7 or 8. No, it was 8. It was 9. Unclear if it was hemolyzed. I think there was probably some component of hemolysis that's pretty high, but he had a urinary retention from maybe a UTI. Let's see. All right. 65-year-old female with pulmonary fibrosis presents with chest pain. What's the rhythm here? Someone's a sinus. What's the rate? What's right? Sinus tach. What are some abnormal features? Someone says Wallens. What makes you say that? So V2, V3 inverted T waves. Do you typically see Wallens in someone with active chest pain? No. So lower on the differential. It could be, but is the QRS, is it low voltage? Actually, maybe, but it could be. Okay. What does alternans make you think of? Tamponade, right? Or pericardial effusion, at least. What else can give you inverted, like anterior T waves? Sinus tach, chest pain. So yeah, so right heart strain, PE. This patient actually had a PE. I think I had this patient. I was like, maybe it's from pulmonary fibrosis. She was like having a lot of chest pain. Ended up diming her, and she had a saddle. See. All right, 68-year-old presents with dyspnea, hypotension, and hypoxia. No. What's this? What's the rhythm here? Someone says tachycardia. Is it sinus? What do you guys think? Just a lot of mumbling. Max says sinus.
Yeah.
What makes you say that?
We were just looking at like G2, B4, B5, B6, all of like this speed.
Yeah, so this is sinus tachycardia. You can see P waves pretty clearly in V1. They're pretty regular. What's going on here? So Max says diffused ST elevations.
Cryogenic shock,
Cardiogenic shock. Okay, from
LAD occlusion.
okay. So this is an MI, right? You have anterior elevations and lateral elevations, and these are actually depressions. I think if you were to quickly glance at this and then look for P waves, this could be mistaken as VTAC, which also is associated with MIs, but this is sinus TAC with a anterior lateral MI. Right. Actually, all right, we can do this real quick. 50-year-old male had severe chest pain, now resolved after receiving thrombolytics. This is like a board question. Yeah. Someone says reperfusion. What is that how you describe an EKG?
Yeah.
Yeah. Just jump into the diagnosis, right? What's the rhythm here? Someone whispered junctional. Is it how is it a narrow wide QRS? It's wide, so less likely junctional unless you have an underlying aberrancy. What? Yeah, so is it so Bilal says this is AIVR, accelerated idioventricular rhythm. Was basically a ventricular rhythm, but it's not really VTAC because it's a little too slow. And this is kind of a reperfusion rhythm after an MI. What do you do with this? What's if they're hypotensive? What do you still don't do nothing? You give them pressors, you give them supportive care, and you kind of expect this to resolve on its own. But if for the second year, so you end up in CCU, you might see this rhythm. Let's see. 37-year-old found unresponsive next to an empty bottle of pills. Also a board question. Someone says bicarb for also not describing the EKG. See, what are some abnormal features here? What's the rhythm? So sinus TAC. Okay. Always interpret the EKG in the setting of the clinical presentation. What else you should be looking for? So why we get EKGs in our tox patients. QTC looks okay. Someone says AVR. What's an AVR? What's a terminal R? What is a terminal R representative or suggestive of? TCA tox. So terminal R is kind of defined as an upward, the positive R deflection in AVR that's greater than 0.7 of the preceding S wave. So does that meet? AVR doesn't meet criteria. Also, you can see right axis here. Also seen, patients who are on TCAs actually can have right axis. And sinus TAC. So this is TCA tox. What's the treatment? Sodium bicarb. Okay. See? Actually, sure, let's do this one. 23-year-old with vomiting, diarrhea, and palpitations. What's the rhythm here? Sinus rate. Sinus tach. Anything abnormal?
After you look at rate and rhythm and accent, what comes next usually when you follow that thing?
With the intervals. Yeah.
What intervals?
I mean, yeah, it could be a right bundle. I think the QRS is actually okay. Yeah. You can also see this. This is similar to my EKG, except not this fast. But you can see like kind of an incomplete right bundle of morphology in young patients. What else? What about the other intervals? QT is long. Okay. So what makes you what do you think is going on here? So max is hypokalemia. What else could give you a long QT? Hypocalcemia. What points? What is this more likely hypocalcemia or hypokalemia? I guess clinically it's probably more likely hypokalemia, but in hypocalcemia, your T wave kind of just moves to the right. So what do you see here besides just long QTCs? U waves. So they kind of mimic SC depressions here, but you can see that I think these are U waves and there's an upright T wave riding on top of the P wave. Sorry. So you can see them here, U wave and then T wave, U wave, T wave. This patient's K was like, I think 2. And if you calculate the QTC, which you should with your calipers and MD calc, it's about close to 520, it's like 524.
Whenever you have a low K, what's the other electrolyte we always look at? Even more than calcium. Man,
Yeah.
you're always going to check that.
All right. I think I'm going to skip through some. I'm going to skip through this one. What else?
So
This is actually a great example of MAT. You kind of see the different P wave morphologies here. But for the sake of time, I'm going to skip through some stuff. Let's see. That's boring. All right. 77-year-old male found outside unconscious. James says neurosurgery consult. This is a 17 hallway patient. You got an EKG because they're an alcoholic. See. What makes you say get a neurosurgery? Also, just jumping straight to the intervention without the diagnosis. These second, third years. Come on. So you have deep inverted T waves that seem almost too abnormal to be ischemia. So this patient had a huge bleed. These T waves they're not only very deep but very wide. The QTC is very long. You can see it in cerebral T waves. All right.
Why? Because it shows up like that. Like why the
that I don't wonder too much. But no, I haven't looked at. I think yeah. The heart and the mind are related. So they interact.
some people take that in mind, oversympathetic discharge, right? And that it may cause a ischemic changes that way, that you get a vasoconstriction. It has to do with maybe the ganglion and stuff and setting off catecholamines.
All right. We're running out of time, so let's get to the next one. This is an 82-year-old male presents with abdominal pain. So sinus rhythm. Okay. Rate. So normal sinus rhythm. How are the intervals?
Why did you?
So wide and QRS, that's good. So what does the wide and QRS suggest? A bundle branch block. What type of bundle branch block? Left. Okay. So because downward in V1 to V3. Is this ischemic? It's actually really hard to tell because this very high voltage, right? No, I found this function on Muse. You can actually decrease the amplitude of the QRS complexes by half. So you kind of look by here. All right, so before we decide whether this is ischemic or not, let's just go over left bundle real quick. So in left bundle, you're gonna have, it's really tricky because you're gonna have ST elevations and depressions. This may be normal. You know, you have big S waves, so you're gonna have ST elevations, and then where you have big R waves, you'll have depressions. And this is known as discordance. So what is there any criteria, you know, how do you know this is a mimic or the real deal? So Felipe says Scarbosa criteria. What are the Scarbosa criteria?
Inappropriate discordance, right? If they're extensive discordance, something like that.
What else? Concordance. So someone mentioned ST elevation is greater than 25% for the preceding S wave. Okay. All right. So this is the original Scarbosa criteria. You know, you guys got all the points, but basically they use a point scale. Basically, if you have any of the first two criteria, it's diagnostic of MI. You know, concordant ST elevation, which you can see here, or ST depression, and originally in V1, V2, V3, and then excessive discordance greater than 5 millimeters, but it only gives you 2 points. All right, but it's sometimes sometimes misses MIs. So there's the Smith criteria, which actually just uses the proportion of ST elevation compared to the preceding S wave. All right, so let's go back to this here. And we could go back to the half. So you guys see anything that would meet Scarbosa criteria? The modified Scarbosa? No, yes. So I think these ST elevations are less than a quarter of the size of the S waves here. So V3, V4, you know, look pretty tall, right? But the complex goes all the way down here. So less than 25%. All right. So this is just a normal left bundle branch block.
Another thing, at downstate EMS will bring you the EKG that they did when they called the pre-notification, and you'll see like V3 maybe has like the elevation that you see here, but it's completely cut off how far the S wave is going. You usually have to wait till you get your own to actually see like actually how far the S wave goes to see if it's appropriate or inappropriate, the ST elevation.
All right. I guess this will be our, I don't know how much time, we're out of time. All right. We're out of time. But we can do this. We just one last one. So 23-year-old female with palpitations, dizziness. Someone says WPW. It's pretty good. What makes you think WPW? So yeah, the PR interval is very short. What else? Delta wave, which leads? Kind of like all the leads, right? I'm most pronounced in these leads. I was trying to trick you guys to think this is left bundle, but I just couldn't trick you guys. But this is type B WPW. You're actually you know typically it's upright in these leads here, but it's down. But this is type B WPW, and that's the end of my lecture. You guys have any questions?